Yeah, I'd like to speak to when we get a little further down the road and we're at the oncologists. And over the years, I've seen the most fierce, adamant arguments against this surgery in HIPEC. And it happens, and some of them kind of range to the absurd, you know, like my own, you know, by then I knew what I was doing, but the oncologist said, there is this guy, Sugar Baker, but he patted me like this, he goes, you wouldn't want to go to him.
It's crazy.
And I said, yeah, pull your kidneys out through your nose. No, he said, you wouldn't want to go to him. And I said, how come? And he said, if you went to him, you'd be disabled. Now, most people would stop there, but I asked him, what do you mean by that? And he looked really nervous. He looked all around and he said, well, it's a really big surgery. You know, it could take you a month. So I guess what I'm saying is that I see all these adamant, it's barbaric, it won't do you any good, you won't do any better there than you would at your local surgeon. There's no proof for it. There are no randomized trials.
It's worse than the disease.
It's worse than the disease. Why are they so adamant? And I would really like to speak that I believe that insurance really drives care too. For instance, your doctors don't have any trouble ever really prescribing something that's in network and available. I think a lot of it is that if it were available within 50 miles of your house, and there were somebody contracted with the insurer that would perform it, I think it'd be a lot easier to get this. I think insurance provides a great hurdle to getting to you at this point.
I think there is something that we have to be careful that we don't give a bad name to the treatment.
Yeah.
This is a complex treatment, and it's not going to be done by every surgeon everywhere. And for example, in the United Kingdom, there are only 2 hospitals in the whole United Kingdom that are allowed to do the procedure.
But they get referred there at least.
They get referred there, and then the institution is approved. You know, actually Australia, the same thing. You know, Australia just accepted this for colorectal as a standard of care for colorectal cancer, and actually we just submitted all the data with them to do a multinational registry for appendix tumors that will be presented in Sweden. But we have to be careful that if everybody start doing these little operations and tell you that we remove 90% is going to be great, we're going to have terrible results, terrible complications, and then that is what many of these physicians do. I mean, a lot of people, you know, for the last few years, there have been few groups that I want to do, and I do one every 3 months, and then we see this patient down the road with all kinds of complications, and the tumor was never removed. Then you really, that creates a bad name.
So you're talking about like standardizing the
standardizing therapy, train people, I mean people that can go to the people who do this and can be trained so they can go to their hometowns and do this operation. Again, this is not just a surgeon operating. This is an institution committed for the benefit of this. I mean, it's a very good, nurses, ICU, everything that goes along to make sure that they succeed, you know. And I think that's what we have to be careful. It has to be appropriate training, but yes, it has to be approved.
So for now, we should have a list of the surgeons that are qualified to perform this surgery.
Well, that's a tricky business, because what does qualified mean? Now, one of my pet peeves is that people read a list from a website, and thank God these websites exist, because at least 5 years ago I had a list, but what I did was write letters to all of them and interview and talk. But people assume that all the surgeons are doing precisely the same thing, and that they all get exactly the same outcomes. And if you start trying to decide who really is qualified or who isn't, I mean, what even are your parameters? Any ideas on that?
We can, the larger places have published results and
Right,
look at morbidity and mortality. The smaller centers, again, trying to get a center going is, you know, you need the volume of patients to sustain to provide the experience for the people doing it.
Well, the only rule of thumb I've ever seen, it was discovered by one of my helpees from forever ago. He found this study, it was out of the same, in Holland, and where they'd studied physicians that were being trained to do this surgery, and they found that the best outcomes started to happen at about 130 surgeries. So I sort of include that in every appeal when I'm discrediting someone who hasn't done very many.
I mean, that is, you know, the number of surgeries depend on who the people are and how they are trained, but I think, yes, you need to be careful. Also, you need to be careful with the publications. When people talk about the complications, you know, you have to see what they're talking about complications, because complications from urinary tract infection, which, people can die from urinary tract infection are never included in these reports. And as well as the mortality, some people will say, oh, no one has died, but yet they left the operator, they live a week later, they die the next day. So I mean, but you must go to centers on a routine basis, very important. And talk to the surgeon, make sure that you actually understand what's going on. I think it's very important like any other disease. And that you understand what the disease is, what it means to you and what it is. But yes, you must go to places who do this on a routine basis. And there are some centers with many people who do it, then you make sure that you are getting to the one of the group that is the most experienced one. Now the good thing about going to centers that have more people doing it, frequently you have 2 or 3 people working together that can help that as well.
But and that's not, this issue of quality is not just an issue with this particular
No,
surgery as well. I
no.
mean, this is actually something that's big, obviously through healthcare right now, but particularly in surgery with large, national efforts to try to define quality. How do we measure it? How do we make sure that, every hospital is providing the same level of quality of care? And then there are all kinds of variables that come into play depending on the population of people that you serve, how ill they are in general, and there's, huge databases and statistical analyses that look at these things. So it gets really, really murky.
But I try to really impress people with the fact that your insurance company doesn't do that. So just because a surgeon is contracted with your insurance company is no measure of quality.
Well,